Hello, mates. It's Rife Nation. Today's all about women's health, but I think actually all the men need to be hearing about this because, to be honest, as a male, I don't really have much of a clue. Yes, I've been a physician for 25 years, functional medicine for 18 years, but we've got a real specialist on the show today, Dr. Carrie Carda, who's an obs and gynae specialist, delivered over 8,000 babies. Can you believe it? And she's looking so good. And she's got 2 master's degrees, which is, my word, in functional medicine, integrative medicine. She's in regenerative medicine, which is my passion as well for many years. Uses platelets and stem cells and peptides, which we do here at the practice. So it's a warm welcome to the Mate is Rife community for Dr. Carrie Carda. Welcome.
Thank you for having me.
Yeah, brilliant. Now, Dr. Carrie, I just want to jump in because people are listening. What is happening with perimenopause and menopause? Because I've never seen so many women struggle with this transition in life. And maybe you want to define those terms and what's happened with some real statistics in terms of women battling with this transition.
Well, I think that we have to understand that there's been a big change and there's been a big shift. And why is that? Why is that such a problem? And I think it all comes back to one thing. It comes back to we're all under so much more of a toxic load and a toxic burden at a younger age. And we've clearly seen how that generation has changed and more that we're exposed to. So there's definitely a direct link to our toxic load, our toxic burden, our ultra-processed foods, our pesticides, herbicides, cell phone towers are going 24/7. You know, we have literally destroyed our sleep patterns. We know that we make our hormones at night, and we know that since this has come around, and we are not getting that 60 to 90 minutes of deep sleep. We're not getting the 6 to 7 hours. You know, we're not getting that. And we know now that all the way from children on up, that it is affecting our overall hormones. Now, if you want to be real strict about the sense of it, menopause has a very defined medical terminology, right? It's an FSH level over 60, right? That's defined it. What's become so blurred now is this notion of perimenopause, or essentially just hormone imbalance. A lot of people like to refer to it as, it's lots of names: polycystic ovarian syndrome, or PCO, or metabolic syndrome. It's getting all intertwined, but at the end of the day, it's hormones out of balance. And when we talk about hormones, we have to remember it's not just estrogen, progesterone, testosterone. It's also cortisol, and it's also your thyroid. So it would be incomplete to not consider all those hormones, and even more incomplete to not understand that simple things like your vitamins and your nutrients affect those, as simple as vitamin D. And so so you have to be very complete when you're talking about this. It's not simple. It's not just straightforward. It's not, oh, you just need hormones. It has to be about the whole person. It has to be about everything.
So someone comes in with symptoms like perimenopause, and so you're saying that definition is hormone imbalance, and then they normally would go to the gynecologist and then get some labs done, and often they're not functional medicine, full spectrum. So looking at things like vitamin A, vitamin E, vitamin B12, B9, copper, zinc, and we can carry on. But they go in and they get either get HRT or they get bioidenticals. You're saying it's a lot more holistic. So possibly take us through your frame, because I think it's very, very important in terms of someone's listening saying, listen, I've got perimenopause, I've got these symptoms, I've just been given these hormones, they've helped, maybe they haven't helped, I'm struggling, I don't want to be taking these, I'm so confused about what is going to be healthy and not. Take us through your process, Dr. Carrie.
Absolutely. And I'm so glad that you're looking at that way, because it is a process, and there's so much misinformation out there. We had a lot of changes in the 2011 study for the WHI study that gave us a big hormone scare. And it was kind of, in my opinion, it almost was, that study has a lot of flaws to it, but it's it was almost a good thing because it opened up the world of bioidentical hormones for us. I think it brought bioidenticals to the forefront. Before that, I don't think there was a lot of attention on that because there is important. And what does that mean, bioidentical? They are still synthetic. You can use the term natural or bioidentical. They are still synthetic, but they are the same identical molecular structure. That's what bioidentical means. I think that's the first thing you have to clear up. So bioidentical means the same molecular structure that your body sees. So guess what? Your body knows what to do with it. It knows how to process it. It knows how to eliminate it, and it doesn't accumulate. So that's the key thing. That's why that's the hormone that of choice for a functional provider. Also, all those studies that have been done so far were not on bioidentical. They were on molecular structures that your body didn't know what to do with. Now, they were the most popular brands and hormones being used at the time, so it would make sense to the investigator to use those back in 2011. But all that scare of I can't be on hormones, and we're kind of ignoring, well, what about the problems when you're not on them? What about the brain fog, the constipation, the skin changes, the joint aches, your tendon pain? We know that you have to preserve that and you have to protect that. So we know it's all about balance too. So that's the other thing that I think it gets overlooked. So when someone comes to see me, I do that battery of labs that you're talking about. I look at their hormones, I look at their vitamins, their nutrients, but I break it down into systems. I look at their blood sugar, I look at their gut, I look at their hormone balance, and I look for nutrient deficiencies. And then I take a really deep dive in looking at their cortisol, their stress hormone. So think of cortisol as your stress hormone. And unless you address each and every system, you're going to struggle to have optimal outcomes. And that's what we all want, right? We all want to feel good. We want to be able to go to sleep and feel rested in the morning. And we lose that if we aren't hormonally balanced. That's when you get the weight gain and the constipation and the brain fog and the moods and the irritability, decreased sex drive, things like that. So I always am I do a lot of hormone replacement therapy. I do it with bioidentical, but I also make sure that I'm balancing and supporting cortisol, and that I'm looking at the thyroid and I'm looking at the nutrients. I do the whole picture together.
So you're a functional medicine, integrative medicine doc who's a gynecologist looking at patients, but it doesn't seem like many gynecologists have gone into this to look at the importance of cortisol and then obviously insulin. I mean, those two, just work synergistically. You get stress down and drives up insulin, and you get a lot of the other symptoms as well. What's been the barrier to gynecologists and then not, going the way of functional medicine, especially here in South Africa?
So I think that's a great question, and it's a huge problem. We're working hard to try to help that. I was one of those gynecologists that was in that trap. I was symptom treating. People would come in, have 5 symptoms. I could give them 5 things to get rid of their symptoms for a while, and they just continued to feel worse. My patients felt worse instead of better. Once you know, you can't unknow, and I wasn't helping them. And as I was learning about treating root cause versus symptoms, I had to make the change. It was a difficult change. It was not supported. I think in the last 5 or 10 years, I think that has gotten a little bit better. There's more education out there. There's more podcasts. There's more webinars. But I will tell you, that has been almost solely public driven. It has, unfortunately, has not been medically driven. So those of us that realized we weren't helping people and started getting some of this extra training, the fact that we were getting people better brought more patients and more patients and more people feeling better. So the public actually created this movement. It wasn't done in the setting of academics. We all know in academics, especially in Western medicine, we're about 20 years behind because we want to stay evidence-based. Our job is to not hurt anybody. And that is a timely process. We also are heavily regulated. So there's lots of licensing. We also are heavily influenced by the pharmaceutical industry, or what we commonly know as big pharma. And they have a big investment that in what it takes to get them where they are. And there's millions of dollars to get their drugs to market. And they have to have a return on investment. And they have this massive, massive marketing monstrous machine that I think kind of holds back traditional medicine. You still today will put 100 gynecologists in one room, and you're going to have 50 people saying one thing and 50 people saying another one. And I don't know the quite answer to that. I just know that doing things like education to patients and letting patients make up their own mind and they find out how they feel. But until we continually I think healthcare is in a big crisis. I think as far as a traditional approach, acute care medicine isn't keeping us healthy. It's great if you break your arm or you cut yourself or you have a wreck, but it's clearly not going to be the chronic. We have to get back to sleep. We have to get back to protecting our toxic load. It's great, all the things that we're doing. I mean, it's great, all this industry and all this technology, but we have to understand that it doesn't come without consequence. So we're going to have to handle the biotoxic load that disrupts our hormones, that puts us in perimenopause 10 years, easily 10 years earlier. So I used to get people 45 to 50. Well, now I'm getting people 30, young. And then you look at our teenagers. You know, we have kids on birth control pills so much earlier. So they're getting all kinds of endocrine changes and birth control. The birth control isn't without its issues as well. I do not like to ever see a birth control pill given out without some supplementation, specifically in the B vitamins. There's a 30% competition going on, so to speak, in the liver for your receptor sites, and the birth control pill just comes in, and I mean, who wants a 30% decrease in their B vitamins? I mean, that's your energy. I mean, B12 does over 600 reactions in your body, mostly energy related, and you just took a 30% cut in that. Who wants that, right?
No one wants that. So let me just frame this: is if someone comes in, you run those labs, okay? Now, someone's listening and they don't have the finances to go to a functional medicine, integrative gynecologist, or even an endocrinologist. What questions should they be asking about because some HRT, synthetic HRTs, even in the box that Big Pharma produces, the estrogen is in the right form, but the progesterone's not. What questions should they be asking with regards to the estrogen and the progesterone they are receiving? Because some people do well on bioidenticals and they don't get much support. And we know the holistic frame is the most important, but a lot of them have problems with low estrogen. So just help someone understand, if they're at a traditional gynecologist, what questions they should be asking about the hormones they're receiving.
That's important, and because I think the gynecologist will be much more open the more you communicate with them. So I think the first thing that you need to know is, are you a candidate for hormone therapy? Are these are my symptoms? You need to present them your symptoms. Would hormone therapy help me? And I think most gynecologists are very open to having that conversation. I think you need to know if they're bioidentical or not. There are even prescription straight estradiol and progesterone are bioidentical, even prescription forms. So they could ask for those specifically, and their gynecologist should know that. So that's important. So you need to tell them, I would like to go on hormone therapy. I would prefer a bioidentical, and they should know that. And if they don't, then I'm not sure you're necessarily at the right office, or you could do your own. But you're looking for estradiol, and you're looking for there is one prescription progesterone out there that's bioidentical. And then you need to talk to them about how can they help you. Ask them, how can you help me balance my hormones? For many people, especially the perimenopausal people, it's going to be just progesterone alone. Just that you don't, especially if you're having a little bit of weight issues, you're kind of your own little estrogen factory. Our adipocytes or our fat cells kind of make estrogen. So you need to balance them with hormones. And then another very, very important misconception, and a thing that I think that needs to be cleared up, is many women will go and they've already had a hysterectomy and they get put on estrogen by itself. You really don't ever want to be on unopposed estrogen. And if they're trying to put you on unopposed estrogen, ask them if you could have the progesterone as well. Because yes, you don't need progesterone anymore for your uterus, but there's a whole lot more to you than that uterus that you used to have. There's your gut, there's your skin, there's your brain, there's your hair, there's your blood sugar regulation. All that, remember, estrogen is a growing hormone. Progesterone is it holds that back. So remember, I talked about balance, right? You don't want to grow. That's why you're going to have trouble with concerns, say for people worry about breast cancer and things like that. Well, you don't want to be on unopposed estrogen, meaning estrogen by itself, if you're worried about growth chronically to the breast tissue, right?
Yeah.
So I'm asking that we stop all unopposed estrogen. And I see that going on all the time here. And that's the first thing. If you're in my practice, I don't prescribe it that way. I don't even allow it. I think it's too dangerous.
What are the non-bioidenticals? Because a patient's going to be in the doctor's office, get the script, go to the pharmacy, get it. Then they got to read on the label. So what are the HRT traditional estrogen and progesterone forms in for a person to look and say, oh my goodness, I don't have a bioidentical? Or, go to the pharmacist and then the pharmacist doesn't know. So what are the names that they're looking for on the box or the?
So the branded name there's only one progesterone, and that's Prometrium. So that specifically is Prometrium. That's the only branded, if you're talking about a prescription that you would receive. Otherwise, you're going to have to get it from a compound pharmacy.
Okay.
And then estradiol, if it says estradiol, then that would be considered bioidentical as well.
And the progesterone, what's the synthetic form of the progesterone that was sometimes used with HRTs?
That's what so like Provera is
exactly
right. Medroxyprogesterone would be the generic version of it, or Provera would be the common that you would that you would likely see probably more often. But yeah, the medroxyprogesterone is that's the synthetic. That's what you're not wanting.
Yeah, it's a progestin, I think, that you don't
correct.
want.
It's a progestin. Yes, it's not progesterone.
Okay.
So yes, it's a progestin, not a progestone. It's the IN or the ONE. Yeah, that's a good clue right there.
Brilliant. Mm-hmm. Okay, so you start that process, and then you want to balance and look at cortisol. Do you do salivary cortisol? Do you do morning cortisol? Do you look at heart rate variability and try and get people to measure that? What's your way to sort of objectify stress? Because it's such a ubiquitous word, and we do a lot of corporate presentations, and then like I say to them, well, how do you know whether you're stressed or not? Or do you have an objective measurement? Are we looking at DHEA cortisol ratio, DHEA? Give us your sort of frame on measuring and monitoring and managing this sort of ubiquitous stress.
So I'm like you, there's so many options out there, and some of them have gotten so complicated and so expensive and so complex that I've just tried to simplify it. I think heart rate variability is a beautiful way to do it, and everybody can do it. You have your watch, you have your watches, you have your Oura rings, you have I love the Oura ring. I look at heart rate variability. If you're not able to keep your heart rate variability in about the 40 range, you have some cortisol challenges. It just doesn't get any simpler than that. If you even want to take it down another notch, if you are getting 7 to 8 hours of sleep at night, but you are not rested in the morning, there's something going on, and it's going to involve, there might be different causes, but you're definitely challenging your cortisol, because you make your hormones at night. And if you're not resting or recovering at night, then you're not making good hormones and you're not going to be balanced. So I think heart rate variability is really good. I do morning cortisol levels at the lab work, in lab work, but I like those, and I use those a lot, but you don't have to do that. But your morning cortisol is where it is going to be the best, because you should have this nice high cortisol in the morning. It takes a drop at about noon, drop in the evening, and then it plummets at night. And what happens is people get, and that's what we kind of refer to as your circadian rhythm. So I talk a lot about circadian rhythm and restoring your circadian rhythm. It's really kind of your cortisol pattern. And we get our days and night mixed up. And again, I blame the cell phone a lot for that. We watch it way too late at night. We have too much blue screen at night, where our sleep patterns are so disrupted that I think that's where it starts. And then the other big factor that plays a role in this, because it ties into cortisol and DHEA and your hormone production, is your vitamin D levels. We are not a country that is outside anymore. And really, without supplementation, I usually recommend between 3,000 and 5,000 international units. We can't keep every day without fail. We can't keep our levels up high enough to protect ourselves. The range is pretty big on our LabCorp labs, but our functional range is not. We know we've got to have these really good D levels. There are studies out there, nice studies out there, that show us decreased levels of cancer incidences, especially colon and breast cancer. And we have all these really nice studies about how your vitamin D level will have a push on the bone marrow to produce more hormones such as testosterone and things like that. So I think what happens a lot is we drop our cortisol because of our stress. We drop our vitamin D because we're inside as we're young adults, and it just keeps on and keeps on. And then the cortisol starts falling, and then the hormones start falling. And then you have what we define as perimenopause, or low testosterone. And really all it is if we had gone back and fixed those root issues in the beginning, you wouldn't be here. And it happens over as much as a decade even. It starts really young, and it progresses very insidious, so you don't know it's happening.
No, it's true. And I'd love to know what your range is. I've been asking this question over the last 4 years. I first did my first lecture on vitamin D in 2003, 17 years ago. And, the ranges that we start to like 30 NGs per ml to 100. And I used to keep patients at 60 to 80 NGs per ml. Then the labs came here and said, oh, no, it's 30 to 50. And at 31 ng per ml, it's based on literature, osteoporotic literature, to make sure that you've got correct bone density. Where do you like to keep your patients? I keep my patients 50 to 60. I like 60 more. I've asked this question many times, but where you're at with that very optimal range of vitamin D?
So I'm kind of a stickler about this. I kind of hold this hardcore. I don't want anybody below 60. I use the range of 60 to 100. And I don't need you over 100. Basically, your one of your biggest risks is over 100, is you can start getting kidney stones and things like that. But it's hard to overdose on vitamin D. Like, you have to work. We're so vitamin D deficient, and it's really hard. There's been a few studies out there that's kind of showing that these really high levels, again, kidney stones. We don't want to give ourselves kidney stones, but I tell my patients, you got to be over 60, closer. For many years I used that 60 to 80, but as our toxic load keeps growing and growing, and we moved on to 5G, cell phone towers and things like that, I between 60 and 100, but my bottom for sure is 60. And what I have found, and maybe you've noticed this in your practice, it's pretty much impossible to do that unless you're supplementing. I see hundreds and hundreds and hundreds of patients, and they can't do it without being on some every day. I challenge, I look forward to the day that somebody comes in and they tell me they're not on D and they've just been outside enough, and it just never ever happens. So you've got to be on vitamin D. We know that arthritis, joints are associated with low vitamin D levels. We know it affects your mood. We just that's kind of just that's a non-negotiable talk that I have with my patients at everybody that I take care of. So I do the 60 to 100 range. If somebody pops back a little high, or if their labs come back, the first thing they're told is get off your D. No, maybe you take it Monday through Friday instead of the weekend, off the weekends, because it only takes about 2 weeks and they'll be back down at 30. That's the other thing you need to know. Don't miss your D.
Yeah, no, it's very, very powerful that. Okay, so there's D that you look at. That's very important. DHEA, I find, and maybe give me your perspective, being a far better way to look at people at perimenopause. You look at the D, you look at cortisol, you look at insulin, and you often can use DHEA before you give hormones. What is your view there? Because I know the conversion is very, very important, but I find it very beneficial.
Absolutely. The other thing too is we seem to be so low on our general LabCorp vitamin D recommendations, where women do wonderful. I'll carry their levels as high up to 350. Men can go up to 500 on their lab levels, and they do very well. You're right; it could be a great precursor. We have to remember that. Your body, in attempt to make more cortisol, an attempt to keep that pathway going, your body uses vitamin D. When we first talked about when vitamin D first was popular, this is several decades ago, we thought it was going to be the fountain of youth. And it was that helpful in energy and just kind of stabilizing your hormones. So and if you think about it, it makes sense, right? It's in the beginning of the pathway to make your hormones. Yes. So if I can't ask you to make chocolate chip cookies and not give you chocolate chips, right? Yeah. So I can't ask you to make hormones if you don't have DHEA. So DHEA generally is, what's nice about it, it's over the counter. So it's not a prescription base. So like for a woman, I'll oftentimes use a 10 milligram or so DHEA, and men about 25. Men do seem to need more than women. That is one of the first markers that I will look at in the perimenopause kind of state, because I know that they've got to be able to make hormones, and they've got to be able to correct their hormone pattern. So yeah, vitamin D or DHEA, which is really a pro-hormone. It's not technically considered a hormone; it's a pro-hormone because it makes the hormones. But that's a good point. You can definitely start with that and see how your symptoms do. You're going to have to give that at least, I would say, 8 to 12 weeks of supplementation before you can really kind of, you have to be a little more patient when you're taking DHEA, and even the vitamin D with it. You're going to have to be a little more patient. But after 12 weeks or so, you should be noticing a difference.
Okay. What about
you find that in your when you supplement with DHEA?
Yeah, no, there's many patients that are in perimenopause. DHEA just really, really works well, and before they take any sort of bioidenticals in that. And I think in this very sort of, distressed environment, draining of DHEA and the DHEA cortisol ratio being, not ideal, I think it's one of the first places to start. And I think it works really, really well.
In your early 40s, especially in your late 30s, early 40s is where I find that is very helpple.
Yeah. What about this whole thing of when patients go to oncologists and then they, either they got parents or they got genetic tests, and then, they got possibilities of epigenetic factors of cancer, or they get diagnosed with cancer. And then the first thing the oncologist says, come off your hormones and no estrogen. And then the patient gets scared. And then the patient tells a friend. And then this friend's like, yeah, I've got all these hormone symptoms. And, you're not allowed to be on estrogen because now you've got a diagnosis of cancer. And I mean, by 2030, we've had a lot of cancer podcasts. 2030, 1 in 2 of all people worldwide will get cancer in their lifetimes. 1 in 3 men, now 1 in 2 men and 1 in 3 women. So what is this whole process? Do the oncologists not see eye to eye with the gynecologist? There's a lot of confusion and patients are coming in very scared of it, not only because of what the public said, but because of what the oncologists are saying.
Great question. I deal with this all the time. So I think first the thing we have to remember is you're talking about two fields that don't necessarily agree, right? There's some controversy. You're also talking about studies that were used on non-bioidentical. So it's based on, remember your body doesn't know that molecule, the studies that they were based on. And there is a lot of controversy between traditional and functional medicine regarding hormone therapy. Now, you do have to be careful, right? You don't want to feed a malignant cell line, of course. I think you have to remember that that physicians and providers have to protect their licenses, and that's what standard of care is. You're going to kind of get that standard answer. Most people aren't going to do much with cancer therapy, at least till you're out that first year. After you've been out about a year of treatment, I think it's fair to go back and to begin those conversations again about hormone therapy. Before that, you're just going to find pretty much anybody reluctant to help you with kind of hormones. Also, remember that hereditary breast cancer is 8%. So it's a small number. It's not, and there is testing for that. There's even genetic testing for that. The BRCA1, the BRCA2 testing for. So I think that this family history thing gets a little hyperbolic attention to. We're all at risk, right? Because we talked about, remember, the estrogen grows and progesterone inhibits, and we make estrogen in our fat cells and in our adipose tissue. So we have to continually be worried about that balance, and that hence the process of the ultra processed foods, the extra weight on you, the inflammation. That's where you need to be putting your attention into, rather than do I have a family history of cancer?
But what about some of these cancers that are estrogen sensitive? I mean, you get a diagnosis and then you're on bioidenticals, you stop straight away. Then the oncologist says, don't ever take this again. Is there space for not taking estrogen, and you've got a lab test of, say, 100 on your estrogen, and progesterone and testosterone and DHEA being far more important than the estrogen? Or because I've got a lot of patients and clients that they've had cancer and they won't touch estrogen again. Is there a space of trying to just get the ratios right between progesterone and estrogen, and then use a bit of DHEA instead of estrogen itself, even the estradiol?
Absolutely. Absolutely. I'm so glad to hear you to be supportive of that. I think the one thing, though, that we have to make sure that's addressed first is going to be the cortisol. When you balance the cortisol, you're going to have the best symptomatic relief, because you'll start doing your own natural balance and your own production. I mean, we didn't have hormone replacement therapy many generations ago because our adrenals and our cortisol took over that for us. Now, we weren't living as long and things like that, but we also didn't have the same exposures. So you could kind of look at it both ways, but nonetheless, by design, the adrenals and cortisol were meant to take over that and to balance for that. So, but you're absolutely right. Testosterone therapy, if monitored, I do want to caution. I do think if you are a cancer survivor, cancer patient, I don't think you should be really doing it on your own. I think you should be monitored. For sure, monitored. But testosterone, you're right. DHEA, I mean, those are all very, very viable replacement to make you feel better.
So what happens to all the
good
blue
point.
zones or people? Sorry, yeah, just like all these blue zones, and before there was big pharma producing all these estrogens. If you had to do an estrogen test on now and go into one of the blue zones, would their estrogen be 100 or their cortisol will be so good and their bone density is so good that they don't need much estrogen, and it doesn't play the role? Is the progesterone and the testosterone, if they have to do measurements, have they done these labs? I'm just thinking before big pharma in the 1890s, if someone reached 70 or 80, their bone density was good, their cardiovascular health was good. I just don't know whether every person would need the estrogen, and whether people that live long in these blue zones, if you had to do a hormonal profile, what does it look like?
So that's a good question, and I don't know that I have that answer as far as in the blue zones. How well have they studied and kept up with that at the various ages and various stages? I do know that they are more corrected for when they go through menopause for age-wise and what you would anticipate. Again, everything that you're talking about, though, and even the blue zones, we know has a lot to do with that cortisol DHEA ratio, that balance there. And I know I keep driving back on that and keep honing back on that, but there's just so much you can do to help your cortisol and to keep balanced. And we know that ultimately it seems to be the big factor in these early perimenopause and helping people in perimenopause. So that's why I keep going back to that. So I think the blue zones are proof of that. That's it, like you said, it's the cortisol.
Yes, you don't actually need estrogen. I'm seeing estrogen dominance in young sort of adolescents now, and people coming to. How do you deal with estrogen dominance? I mean, there's just so many xenoestrogens out there that are causing a lot of problems, and the progesterone's getting hammered, and the testosterone. Give us a bit of a frame, maybe define what estrogen dominance is. Someone's listening saying, okay, I don't know what this is, and then what they can do.
Estrogen dominance, we like to refer to it as medically, it'll be your polycystic ovarian syndrome or your PCO. So an estrogen dominance will tend to be extra weight on you, especially around the middle. May or may not be night sweats, hot flashes. Estrogen dominance can have brain fog, constipation, things like that with it. So we definitely want to recognize it, and we definitely want to treat it. And I'm sure you've seen how young that is now. That's in teenagers, right? And then you also alluded to it before, how insulin becomes into play. And then you begin having what we call your insulin resistance. You're not as responsive to your insulin as you once were. So it might take 4 molecules of insulin to grab a glucose instead of 1. You just become so inefficient at how you manage your blood sugar, which then just it just cascades down even further. I think that estrogen dominance is probably one of our biggest issues that we're facing, and I think to the public that's obesity, but I don't think we're looking at the cause. Hands down, I think this ultra processed food and a lot of these exposures to water bottles, the BPAs and things like that, have become the issue.
So how do you treat it? Do you use supplements, and do you use DIM, or do you R3C?
Yes. So I use a lot of DIM, about 100 milligrams of DIM to support that. I try to get more to the glass bottles instead of the plastic bottles. I think any effort made to do that is helpful. And I think it comes back to getting away from the ultra processed food. Just getting back to, just if someone asked me how do I need to eat, if I could even just simply get them to meats, fruits that end in berries, and vegetables with the exception of corn or white potatoes, I I even just doing that is going to have such a profound impact. Just that if it just needs to, those three questions, is the food you're eating match those three questions, then go for it. I'm not even necessarily going to restrict how much you're eating. I am going to restrict what you're eating though.
Yeah.
And of course, no soda. The soft drink beverage industry is it's been a problem because it's in such a young age. Well, one or two here or there hurt you. We're designed to handle toxins, but we're not designed to handle that many toxins at that young of an age all the time, 24/7.
Okay, so people are listening now, their kids and their daughters going through precocious puberty like never before, and I've released some content on melatonin inhibiting these sex hormones, and so if we've got less melatonin, we're not sleeping properly. Now we get precocious puberty coming through, and instead of 11 and 12 or 13, it's 8 and 9. How do you cope with this? Because often parents will come in and then they've already been to the gynecologist or the endocrinologist, and their 12-year-old who's struggling is on a contraceptive pill or is on hormones at a young age. And I think this is causing significant problems. But just because of the fast pace of modernity, they're taking the easier option, or they just listen to their doctors to say, okay, your child, got significant premenstrual pain and has got acne, so here you go. It's clear to your skin, and take a pill. How do you manage these things, and what do you think of that?
So it's a huge problem, but it's a very real problem. So and if they're going to be on birth control, the first thing is, remember I talked about the B vitamins. So I want them on a multivitamin, a methylated multivitamin for sure. I don't put the two, they've got to be together. I also want to support their D vitamin like we talked about earlier. And then I walk through the process of when are they going to bed, how many hours of sleep they're getting at night. I do encourage activity. Of course, we do that with all our kids, right? For just their overall health. But I do have that conversation again because we're so sedentary now, and our children are so sedentary. So also just getting outside, being out in the sun. The other big thing that I have found that seems to be helpful with this young age group and this whole I feel like we've moved them up 10 years, almost 5 years for sure in their hormone status and in their age. Really, we've advanced our small children's and I talk a lot about breathing, deep breathing. Even if it's just simple as box breathing, or even for children, just as simple as 2 quick breaths in and 1 long breath out. Just do that 5 or 6 times. Or the other thing is box breathing, and I do this because of heart rate variability and cortisol, but you breathe in for 4 seconds, you hold it for 4 seconds, you breathe out for 4 seconds, and then you complete the cycle. So it's 4, 4, 4, 4. And it even just doing that twice does a lot to change that sympathetic response, so you're not deriving that cortisol. Because with children and adults too, to a certain degree, it's not that it's not that we can't handle the load and we can't produce cortisol. It's just our brains get tired of it, and they get tired of constantly being bathed in cortisol. So you will actually turn off that pathway. You actually shut it down. It's a survival technique. So the whole idea is to wake it up again. Give yourself the nutrients. Take some of the ultra-processed toxins away. Do the breathing. Control that sympathetic tone, that fight or flight that we know. Kids, I think, spend a lot more time in the fight mode than they ever have before. And most of that's through devices and through gaming and and through processed food and fake sugars and things like that, dyes and stuff. So they're very sympathetic all the time. You can look at all their eyes. They've just got these pinpoint pupils all the time, these little kids. And if we can do the breathing with them, get them out in the sun, keep their vitamin D up, definitely their B vitamins, the methylated vitamin, and then get them to sleep. So a structured sleep pattern is probably the best, especially when you're in that prepubescent and then reaching puberty and getting on the pill and things like that all at once. The sleep structure pattern is going to be important.
Now, do you do that before and you don't recommend the pill? I mean, if I have to push you in a corner, is like a 12-year-old and 13-year-old should be taking the contraceptive pill?
So if you don't even have to push me in a corner, I'll just flat out tell you, I don't think it's the best option by any means. I think the birth control pill should be used for contraception only. If that should be the purpose of it. If someone comes in with heavy cycles or abnormal bleeding or regular menstrual cycles or things like that, I don't ever jump to the pill first. And I think that's the big difference between a functional practitioner and a traditional. You can use progesterone. You can use bioidentical progesterone because these kids are probably getting a little on the heavy side. They're probably that estrogen dominance we keep talking about. So we can just give them progesterone for half the cycle and maybe do that for 3 or 4 months. Get their vitamin D up, get their B vitamins in, and just maybe alter their diet, breathing a little bit, get them to sleep better. They tend to do very well. Magnesium is another great supplement for this age group. Anywhere between about 100 milligrams or so, maybe even 200. That at night, calms the nervous system down, calms the sympathetic system down. So yeah, I very opinionated on that. I don't think we should be putting these kids on these birth control pills, these synthetic hormones that they don't even know how to process at 12 or 13 or 14.
Any other supplements that you found have been very beneficial for estrogen dominance other than DIM?
For estrogen dominance, well, progesterone has always been my favorite to balance it. DHEA, very good, like we talked about. DIM is good, or any of the greens. So sometimes just doing a green supplement, if they're not going to get the vegetables, there's lots of green supplements out there, especially for kids, or there's green powders. Even just doing that, you'll get similar benefit. They make different gummies and different ways to get vegetables into the greens into the kids is a really good way. But DIM's nice. DIM's easy, and it's easy to get, and it's safe, and so DIM is really nice.
Brilliant. Tell me about just, I don't know, your ideal ratios, because I normally run tests 4 weeks in a row, same day, same time. The estrogen progesterone ratio, do you have something ideal in terms of your estrogen testosterone ratio? Someone's listening saying, geez, the beginning half of the month I'm in trouble, then I'm a bit better in the second. Do you do any of that sort of weekly testing and look at ratios?
So that's a little bit of a tough question, in the fact that what truly is the best way to measure? That you could put 100 people in a room and have 100 different answers of the best way to truly measure estrogen, especially in women. And the idea is, I think, probably serum has been the most popular. You could measure it in urine, you could measure it in saliva, you can measure it in capillary blood or with the finger stick, or you can measure it in the vein, like from the arm. Probably the most common still is measuring it from the arm, which, just because it's in your blood doesn't necessarily mean that it's in your tissues, that it's reached your receptors. And that's why it's not as accurate as we would like for it to be, because we talked about all these toxins we have, and they bind up the receptors on our cells. So you might have all this estrogen floating around in your serum, but it's not getting where it needs to go. And unfortunately, that is a pretty big problem. And so sometimes our serum levels aren't you just can't quite be exact with it. But in general, you can divide your progesterone by your estrogen, and you want that to be about a 1 to 500 ratio.
Okay.
But I like to generally, when I look at my blood work, see the progesterone depending on where someone is in their cycle, right? Because you have two different phases to your hormones, right? But if you're in that last phase, I like your progesterone to be about 20 times what your estrogen is. In the first phase, you're gonna see the opposite. You're gonna see almost no progesterone, because you grow in your first part of your cycle. Your uterus, that lining has to grow, and then it has to shed, right? The second half. So where people are when they get their blood, it makes all the difference in the world. That's why it's so hard. That's why people never know what to do with their hormones. Which phase are you in? Which way did you measure it? So I hate to get really, really, I hate to hang my hat on people's levels. That's why I like what you said in the beginning, and that let's just look at symptoms. Let's just look at heart rate variability. If you're not cycling normal, then you're not balanced, right? If your menstrual cycle is supposed to be normal, right? It's supposed to have a normal circadian rhythm to it. So something's not balanced if you're not. I don't care what your blood test is telling me. So I do think that we can use that analogy a lot more than what we do, than just those actual blood levels themselves, because they vary so much from age, toxin exposure, and weight, and if you've had a hysterectomy or not, and how did you measure it, things like that.
Cool. Well, we're coming to the end of the show. Just maybe give a message of hope, Dr. Carrie. I mean, I've said this many times before. I've never seen so many sick people at a younger age, in 25 years in practice, and people just are struggling hormonally. Testosterone has dropped in the last 20 to 30 years, free testosterone by 45%, and that's male and female. There's a lot of despair out there, and without good hormonal balance it's your foundation. If you don't have good hormones, you just have the inability to be resilient and be anti-fragile, and all these psychological frames that are so important, and mindset's important. But without the correct biology, it makes life very, very tough. So maybe just give a message of hope, people listening out there, because at the end of the day, these podcasts, they do make people aware of, how problematic society's become, and the sickness and disease. But I do want to make them, filled with hope and empowered to, take the knowledge, ask the right questions, and make the right decisions.
Oh, absolutely. I mean, that's why I'm doing what I'm doing, and why I love it, because it was a complete 180 for me on how I practice. So it was hardcore gynecology, and when I went to the functional world, because people got so much better. I stopped treating symptoms and I started fixing root causes. And I've been doing it long enough now that's what keeps me going, because I get to see the benefits. But I think the important thing is you can do this yourself. You can get a device, and you can look at heart rate variability. You can do symptom tracking on, are you regular? Do you have night sweats, hot flashes? Are you fatigued? Do you have brain fog? Do you have constipation? I mean, you know that yourself. I think fatigue and weight are probably my two biggest ones that bring people across my doorstep. So then you have to go to work, and you have to go to work at getting rid of ultra processed food. You need to get your vitamin D in shape. You need to get your B vitamins in shape. So that's usually through a multivitamin. And there's even progesterone over the counter. There are DHEA is readily available. It's not expensive. And there's all kinds of cortisol support that you can get on. There's ashwagandha, rhodiola. I mean, the internet has made it so valuable for us, because we now have access to those things everywhere. And so again, the cortisol support, and then the breathing. The box breathing is simple, or even just as simple as 2 quick breaths in to fill your lungs and 1 long breath out. And magnesium to help. So I know I throw a lot of things out there, but all that is available to you. It's all out there, and it's all, you can begin to see how you respond. Remember, give it a few weeks, and if not, then adjust some more. You may not get it right away, but you got to get to sleep. You got to get your nutrients up, and you got to get rid of some of these biotoxins, and that's probably going to be mostly in ultra processed foods.
Brilliant. Well, I want to just declare favor and blessing over you. Thank you for your courageous calling. Thank you that you've stepped out. You've done a lot of study. You've got a lot of experience. So the combination of getting your master's and just really working at it and just getting out there with the podcast, very, very grateful, and just want to honor and salute you for all the work and your time on the podcast.
Oh, and thank you for getting it out there. I mean, we can be in the trenches but it's the people that did this, and it's people like you getting it out there that made this movement possible.